who will be present today. So we are
Right,
streaming
right.
live on YouTube.
Now,
We will
Parul,
also
you
share
can
the
admit
link with
everyone
you,
now.
Dr. Medhavi.
अभी आप एडमिट कर दो पारुल।
अब मैं देख नहीं पा रही हूँ, कोई मैं को होस्ट हूँ नहीं शायद।
एक मिनट, आप तो को होस्ट हो, मैंने तो आपके सबसे पहले बनाया था। एक मिनट, आई जस्ट चेक। अरे
So try admitting those who are present right now.
आप ही को होस्ट हो गए हो पारुल।
जी शुक्रिया।
थैंक यू।
Parent, we would request if you can rename yourself other than your phone name. iPhone, we would request to rename. Rashmi is not able to join, Brinda. She said the message came that you have been removed.
हाँ, वो वृंदा जी ने उन्हें गलती से रिमूव कर दिया था, तो उन्होंने फिर मैसेज
Now
भी।
she's not able to join, I guess, again. मैं फिर से
I
लिंक
will
भेजती हूँ।
I'll have to check, Sammy. I'll just check, okay?
जी 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 जी। I'm so happy to see Rama ma'am with a video on.
Shall we start, वृंदा जी? Thank you. नमस्ते दोस्तों, मेरा नाम पारुल सिंह है और डाउन सिंड्रोम फेडरेशन ऑफ इंडिया के शनिवार के सेशन में मैं आप सबका स्वागत करती हूं। मेरे साथ हैं मेरी दोस्त समीक्षा सजवान और डीएसएफआई से हमारी दोस्त वृंदा जी हमारे साथ हैं। आज हमारे लिए सौभाग्य की बात है कि डॉक्टर रेखा रामाचंद्रन, प्रेसिडेंट डाउन सिंड्रोम फेडरेशन ऑफ इंडिया भी हमारे साथ हैं। पिछले सप्ताह किन्हीं कारणों से वो हमारे साथ नहीं जुड़ पाई थी, जिसके लिए हमने उन्हें बहुत मिस किया है, तो आज हम उन्हें भी सुनेंगे। आज का जो हमारा टॉपिक है वो है चाइल्ड साइकोलॉजी का। क्या ऐसे कारण हो सकते हैं जिनके लिए एक साइकोलॉजिस्ट की ज़रूरत हमें पड़ सकती है, अपने लिए या अपने बच्चे के लिए? सबसे पहली बात तो ये है कि साइकोलॉजी अब वो भी सब्जेक्ट नहीं रह गया है, या साइकोलॉजिस्ट की हेल्प लेना वो भी नहीं रह गया है कि आपको बुखार जैसी कोई चीज़ हुई है या वैसी कोई परेशानी हुई है तभी आप साइकोलॉजिस्ट के पास जाएँ। आप अपनी रोज की समस्याओं के कारण भी, लाइफस्टाइल के कारण भी बहुत सारी चीज़ें ऐसी हैं जो अनसुलझी रह जाती हैं हमसे। आज की आपाधापी वाली ज़िंदगी में हम जिन चीज़ों को खुद नहीं सुलझा सकते हैं, तो क्या बुराई है उसमें कि किसी एक्सपर्ट की हेल्प ली जाए? क्योंकि अगर हम इधर-उधर से हेल्प लेने की कोशिश करेंगे, सब लोग हमारे जैसे ही तो हैं। जिन लोगों ने अपने ज़िंदगी के बहुत सारे साल उस तरह की पढ़ाई करने में गुज़ारे हैं, उनसे हेल्प लेने में कोई बुराई नहीं है अपनी ज़िंदगी को खूबसूरत बनाने के लिए। तो आज का सेशन उसी चीज़ के नाम है। हमारी गेस्ट को आमंत्रित करने के लिए हमेशा की तरह मैं समीक्षा को आमंत्रित करती हूँ। हमारी जो आज की मेधावी गेस्ट हैं डॉक्टर मेधावी सूद, उनको आप आमंत्रित करें समीक्षा।
Thank you so much, Parul. Good evening, everyone, and welcome in today's session. Yes, Parul, you rightly mentioned our daily lives are deeply impacted by the interaction of our biology, relationships, and mental processes. Learn and improve your understanding of your greatest asset, that is the human mind. And as humans, we have advanced in studying about every living being on this planet. Humans have not only studied cognitions, emotions, and behavior and expanded their understanding, the role these factors play in influencing health, happiness, and overall well being, but have devised and has earned expertise in tools and techniques to make humans more productive or motivated and overcome issues which prevent them from living up to their full potential. Today, we have a very sagacious and highly qualified clinical psychologist with us to empower us through her experience. about behavioral changes, the reasons behind a peculiar behavioral pattern in our self-advocates, exhibit sometimes while growing up, and will also guide us how can we manage it in day-to-day life and when to seek experts' advice. Dr. Medhavi Sood, a RCI licensed clinical psychologist, has been caring and guiding the neurodivergent children and their parents along with general population from years now. And I guess it will take a few hours if I really start talking about her qualification and publications, the papers she has presented at different conferences, at different levels, the number of conferences, seminars, and webinars she has attended and has been part of, and her achievements and contributions in the field in which she is working. So I will skip it. Sorry, Dr. Medhavi, because you will certainly understand, or once you hear her speak here. But before we hand over our audience to her, we would also like to mention that about two important persons with us. We are hopeful they will join. Brinda will let us know when they come. From IAP West Delhi branch, Dr. Dinesh Goel, a trusted pediatrician of Delhi, President IAP West Delhi branch, a very kind and supportive person he is, who upon reaching out immediately agreed for connecting us to the right expert for today's session. Sir, we are looking forward for this to become a regular fare among us. I'm sure this request will reach him. And last but most important, our unwavering support in Delhi NCR and a fellow comrade in the cause of Down syndrome. Her spirit of contribution has always been so strong and inspiring that since the day we have connected, we always felt she's part of us. That is Dr. Smita Mishra, one of the best pediatric cardiologists in Delhi, practicing in Manipal Hospital and president-elect for IIP West Delhi. So a very deep gratitude to both of them. And of course, they will join us soon, and their presence will make us feel so encouraging. So coming back to today's session, before we hand over our parents to Dr. Medhavi, yes, we extend a very warm welcome to Dr. Medhavi Sood on this platform. We would like to invite Dr. Surekha Ramchandran to please speak a few words before our experts start. Ma, over to you.
Good evening, Dr. Medhavi. And to everybody on the show, but Dr. Medhavi, thank you so much for giving your time. This is a subject that is closest to my heart. And actually, I am going to meet the psychologist and the psychiatrist this evening because Bubbly needs a lot of, she has a lot of mental health issues, which were decried 25 years ago. Let me honestly tell you that 25 years ago, when we talked about mental health, they thought, the word was taboo and you can't have any mental health issues unless you were a weak person. So they always addressed you as a person who could not face the challenges because they never understood any of the chemical changes in the body. Today, of course, with
Ma, you got muted.
Oh, yeah.
Yes, abhi theek hai, ma.
No, it's like any other part of your body. Like I always say, if you have diabetes or you have hypertension or you have anything else, please understand that your mind is also playing havoc along with everything else. So many of our children, without realizing it, are facing tremendous issues, which I think for the parents to first come to realize it's very difficult because they, the fact that you have to go and have your child screened for a psychological issue is very difficult because you don't want to think that your child has got any mental health issues. And I want you to clear this entire thing in their brains that like everyone else and like anything else, this is a part of your body. It is not something that is not, going to happen to our children. So it's very important that we have people like you very close to our organization because it starts with childhood. And the pressure on a child is so intense because the parents themselves are going through so much pressure. So it's an interrelated subject. that I want you to address. And thank you so much for coming. I couldn't sleep from the morning when I read about you, because it is something that I've been wanting to bring people into. And, to try to explain the subject itself takes time. So thank you so much. I'd love to hear you out, and then we will give you our feedback. And thank you again and again and again for your time. Thank you, doctor. Thank you so much.
Thank you so much, ma'am, for welcoming me here like this. I'm quite humbled.
So we are all waiting to hear and learn from your experience today.
All right, ma'am. I will just give me a second. I'll just share.
Ji. By then, I will like to request all our parents to please switch on your videos. It looks nice when we see eye to eye. Yeah, Dr. Medhavi.
Ma'am, is this visible?
Yes.
All right. Hi, everyone. I am Dr. Medhavi. I am not just a clinical psychologist, but I'm also a child psychologist. I deal with children on a daily basis, not just behavioral problems, but I also deal with kids who are differently abled. So I'll straight away jump to the topic at hand today and not waste much of your time. So when Down Syndrome Federation of India had approached me, they wanted to specifically discuss a topic which is quite close to their heart, which was behavioral difficulties that children have when there are children with Down syndrome. Right. So I'm not going to go into the details of what Down syndrome essentially is, or why it happens. I'm pretty sure that everybody here listening to us today knows what it is and why essentially this is happening. Right. So I'll just jump to the topic and keep it as brief as possible. Right. Okay. So what we call as problem behavior is essentially things that are not considered as acceptable in our society, or at least in our daily life, right? So any behavior that falls into that category becomes a problem behavior. And it can be anything from screaming to shouting to throwing some tantrums. It can also be when the child becomes very stubborn in some sense, right? All of these difficulties essentially come into that specific category. Right. So there is no one particular unique problem that is known to be a problem with children with Down syndrome, essentially. And most of the difficulties behaviorally that they usually face can be related to their mental developmental level, right? Not their chronological age. Just to give you a brief background, there is a difference between developmental age versus chronological age. So Dr. Rekha will be able to, of course, better explain all of this, but chronological age essentially is your biological age. That starts from the day you're born and ends on your death, right? Developmental age essentially is how old you are mentally, to put it very, very simply. So when we say that there are some behavioral difficulties, what we essentially mean is that it is creating a trouble because related to their developmental level, right? So essentially that. So just moving forward as to why these problem behaviors exist in general. So to put it very, very simply, we call it 4 A's, right? So the first one is avoidance. So they essentially want to avoid or escape from a particular task that you're probably making them do, or some behavior that you've been trying very hard to teach them, but it's difficult for them to learn, or they are wanting to avoid or escape some form of activity or situation that you are wanting them to be a part of. The other, of course, is that they want to access something. Can be an object, can be an activity of their choice, can be a behavior that is easy for them to do, or accessing a situation that they want to be in. So there can be behavioral problem to gain access to any of these particular behaviors, objects, or situations. Next is attention. So when we talk about attention, what we're essentially saying is that they want to gain your attention for anybody who's around them. And what are they going to gain from attention? The whole fact that attention on them is there is what they're probably looking for, because of which there is some form of problem behavior itself. And last but not the least, it can feel very automatic to them, or a behavior can feel very good to them. So one example of an automatic behavior is two things. Essentially, let's say you're feeling thirsty, considering at least Delhi is boiling at plus 50 degrees Celsius right now. So every time that you feel thirsty, there is a glass of water on the table itself. You will simply pick up the glass of water and have it, right? That's an automatic behavior. Why? Because it's natural and it feels very good, essentially, right? Next, of course, any behavior that is automatic is when you were young, mothers would constantly keep saying that don't come near the gas stove, you will burn your hand. So every time that you feel something hot or you hold something hot, it's an instant reaction to pull your hand back, right? That is something of an automatic behavior. Two examples of the automatic behavior. So even a problem behavior can feel very automatic to the child itself, right? It's easy for them to act that way, right? Also to keep in mind, of course, that automatic that problem behaviors can also sometimes serve the function of communication itself, right? So kids can also communicate through certain problem behaviors. We'll of course come to that in a few later slides, right? So all behaviors have meaning, and it is functional for the person showing that behavior. And children tend to engage in the negative behavior because it is meeting either a need or a function for them. And of course, like I said, that behavior is a form of communication. And one good example of normal human behavior is when you're happy or you feel happy with somebody, we either go and hug them or we hold their hand. So that is one good example of good behavior, so to speak, right? So behavioral difficulties that children with Down syndrome can have is that they can have a problem in controlling their impulses. So what we mean by impulse.
मेधावी, पेरेंट्स क्या प्रॉब्लम आपको आ रही है ऑडियो में? क्या आप सभी को सुनाई नहीं दे रहा है? ऑडियो में कोई प्रॉब्लम आ रही है? कंफर्म करेंगे प्लीज पेरेंट्स?
Not at my end, Parul. I think those who are not able to hear can join again with their audio connected.
Parul. I think it's an individual problem.
Specific.
Perfect.
आप जिनको भी आ रही है प्रॉब्लम, तो जैसा समीक्षा ने कहा है, आप प्लीज दोबारा रिजॉइन कर लें. थैंक यू जी.
Join. Yeah. Otherwise, we are live on YouTube. Yeah.
All right.
Yeah, Dr. Medhavi.
So, like I said, one problem is that they can have difficulty in controlling their impulses. So what we understand by the word impulse essentially is whatever comes to their mind without having to put any thought to it, or what the consequences of any behavior can be, whether somebody can get hurt or not. They will just simply not think about anything of that sort and just go right ahead and do that behavior particularly, and that is what can cause some or the other difficulty, right? Next is communication. So like I said earlier, then some or the other problem behavior can also be a form of communication itself. So sometimes biting, for example, can communicate a need, a sensory need specifically, right? Next, of course, is they can have difficulty in relating to people around them, whether it be a child or an adult. So, for one good example is recently I saw a child with Down syndrome, where he would essentially turn away from anybody who would raise their voice. So he was essentially showing the behavior of turning away by expressing his dislike towards loud voices, essentially, right? So if children are not able to relate to child, either adult or children, even then they might be able to show some form of problem behavior, not remaining in that room. If somebody is screaming or shouting or raising their voice, that can sort of sometimes feel like a problem behavior to certain people, essentially. Next, of course, is that they might have some or the other form of difficulty in managing frustrations that they have. If communication in general is a problem with them, then of course expressing their frustrations itself can be very difficult for children with Down syndrome, right? Even sensory needs, especially Down syndrome children with some comorbidities like autism or ADHD, they can also have sensory needs where they hit or bite or run around or are hyperactive in some sense. All of those can also start to feel like difficult behaviors to deal with. The other things that can, of course, cause some behavioral difficulty is that the task that you've given, it might be too hard for their mental level to finally start and then achieve the desired result in that particular task itself, right? So that achievability of the task itself can be too hard for them. Next, of course, is that they might require more attention. Now, every time need for attention can also indicate sometimes that there is some difficulty that the adult is not able to figure out, right? In those conditions, essentially, further help is required, help of a professional essentially is required, right? But if it's a plain simple need for attention for whatever task that they're doing currently, or they want some appreciation in general for the task that they've done, just finished, even that can sometimes feel like a problem behavior if that's occurring too frequently, right? For every small thing when they're done, they can ask for attention, they can pull your attention. They are known to even pulling your hand, taking you to the room where they've just finished the activity itself, right? So in that case, they require more attention. Next, of course, it can also be that you're busy somewhere, you've just told them what to do in the activity, not clearly explained the activity to them for their mental level or developmental level, and you left the room, right? So maybe explaining more clearly is what is required. Even that can not just have become a behavioral difficulty, but it can also lead them to be doing the task itself in an incorrect manner or a wrong manner or a haphazard manner, which can lead to further more difficulties rather than solving the problem. So check if just explaining more clearly is what is required, which is leading to a behavioral difficulty, right? Or of course, it can also be that they don't currently have a sufficient personal space to be functioning in, which can also lead to some or the other behavioral difficulty itself, right? Just to mention a few comorbidities that are currently known to us for children with Down syndrome. During adolescence and young adulthood, you start seeing things like anxiety and depression, which have now become very common. Even psychosis or schizophrenia, or just plain simple social withdrawal. Social withdrawal is when you start excluding yourself from social gathering or meeting people in general, or you prefer to stay within the house itself, right? Others, of course, are quite known. Things like autism, ADHD, aggression in general, any kind of repetitive movement, especially for children who have a comorbidity of autism. Repetitive movements are very, very extremely common itself, right? Um, so what do we do? What do we do when we have all of these difficulties is what we need to be understanding today in a bit more detail, right? So steps of how you find out what the difficulty is. So you first, of course, define the problem that you currently have at hand. Then you devise a plan to understand why a problem behavior is occurring, how many times it is occurring in a single day or maybe in a week, and what is the result or what are they gaining from showing that particular behavior. Are they getting the attention that they require or something else is what we need to understand in collecting the data part itself. Next, of course, is that once you have the data at hand, then you analyze the data and then you understand and hypothesize how to deal with it. Once you hypothesize, then you, of course, develop a intervention plan and use it. And once that intervention plan is in place, then you monitor on how that intervention plan is working and how is it affecting the child, and is it actually stopping the problem behavior or increasing the problem behavior in turn. So essentially, these are the steps in which we try and understand things when it comes to any form of problem behavior, right? So just to give you a brief about how a problem behavior occurs, it's called as the ABC model. So A is the antecedent. Antecedent is also called as the trigger. So anything that comes before a behavior. Now, urge, need for something, need, sensory need, urge for food, or any hunger, thirst. So trigger is the hunger or the thirst. Behavior can be that they can go and start to stand in the kitchen, or they can start to move the utensils around in the kitchen to find some form of food so that they can sort of quench their hunger. And consequence essentially can be that they've probably broken a glass while turning the utensils here and there. They have broken a bowl or something. So the consequence would eventually be that you end up scolding them or something like that. But what actually triggered their behavior was hunger or thirst. So maybe understanding this whole cycle will help you understand that whenever the child is hungry or thirsty, they start to move the utensils around them. And that is how they depict their hunger and thirst. So maybe at that point, simply giving them something to drink or eat is a easier option, essentially, right? So when we go about doing behavioral analysis in these kids, essentially, ABC model is what we end up following, essentially, right? So any questions so far from anyone?
अगर पेरेंट्स का अभी तक की प्रेजेंटेशन में कोई सवाल है तो आप पूछ सकते हैं। या फिर आपके अपने पर्सनल कोई सवाल होंगे तो प्रेजेंटेशन के बाद आप पूछ सकते हैं डॉक्टर से। थैंक यू डॉक्टर, प्लीज कंटिन्यू।
Dr. Medhavi, there is one question. Now,
Yes.
parents get back to me saying the child is very aggressive, and not only is he throwing things, he hits everybody around them. So, this is also caused because of a particular trigger. Now, what is the parent's reaction is so vital in this point. I think more than the child, I think we have to tell the parents how their behavior should be at this point of time, because they call me up and say they get irritated. Now, irritation is a natural emotion which comes because you might have also been, having a tough day or a very tiring day. But that is not going to solve the situation as per the needs of the child. Because, and also, Dr. Medhavi, I want to tell you something that the behavior is not very different for the so called typical child. My grandchild also behaves like that when he is hungry or he wants a particular thing. So, what he does is he cries or he gets more aggressive. So, you have to read into the mood of the child and be in tune with your own child, because a third person might never be able to understand the need of that hour. So, I think any behavior is either might be something that is copied. It could be something that is trying to express a need, or it could be that they are just being difficult at that point of time. So I think the parental situation is very difficult, and I think I find a mood dip with a parent rather than with the child. Do we ignore these behaviors, or do we address it always, or is it good to just walk past? I just want an answer from you.
Right, ma'am. So, what is to be done when the child is getting aggressive essentially entails a few steps, just to answer you. One, finding out the reason for the aggression. That's one thing, of course. Understanding the need of the child itself is what is the most important thing. Secondly, frequency of it, urgency of it, then the consequences that the child is having is what needs to be understood. That's the first thing. Second thing, of course, is that any form of aggression is always a no. So it's not a good thing. They will continue if it is reinforced. If you ignore it, if you end up simply ignoring it or appreciating it, that's going to increase. So addressing it and solving it out essentially is what needs to be done in very, very simple terms. How it needs to be addressed will depend on, of course, what the trigger is, why it is happening, what the need of the child is, and essentially speaking, what are the consequences of the aggression that the child is getting, will depend on what technique needs to be used. So I will be discussing a couple of techniques in the later slides now. So maybe that should help you deal with how to stop or at least address how they're supposed to be addressed itself. Ma'am, I hope I have answered your question.
Medhavi, sorry, there was another issue that I had. Most of the parents are working parents. So when a parent goes to work, the child is either left with a caregiver or the grandparents. Now, if a child behaves like this, normally the grandparents or the caregiver gives in to any demand that the child might have of that particular need. Is that going to aggravate the situation, or is it going to create a more of a confusion in the child's brain that one is saying yes and one is saying no, which is so apparent? And I find that these are very difficult situations, because we don't like to tell the parent anything, because working, because of the economic status, we have to support them. But at the same time, when they cry to us and say that it's becoming worse by the day, uh, do they tell their in-laws or their parents that, don't give in? But it doesn't work that way. So I'm finding the pressure on the parent immense. And I think at least 80% of our people are going to work. So how would you suggest they tweak the situation to be able to, help themselves and the child?
Right, ma'am. That is not just a difficulty with Down syndrome, but also with any child who's differently abled. That's the first thing that I would tell you. I started practicing back in 2016 itself. So this is a difficulty that we've been seeing since I was studying myself. Um, to give you a honest answer to the question that you've asked essentially is that nowadays when parents come for what we know as behavior therapy, or what is essentially required to solve all your problem behaviors, what parents have now started doing is it's not just the parents that we are helping out, it's the entire families. So on ground, when we see, then the other good thing that has started to happen, which is helping us essentially, is that because parents are at work, grandparents are the ones who bring the child for therapy, essentially. So it becomes easier for us to educate the help that the child is with, or the grandparents itself, to help them educate, tell them certain techniques, tell them the do's and the don'ts of how to deal with the problem, which essentially solves 90% of our difficulties. So just the parents alone, no, that's never enough. Everybody is working in today's day and time. Every parent, whether it be work from home or, of course, going to the office now, post COVID, but child is either left with the grandparents or left with some nanny or somebody. So essentially, everybody has to be educated so that the problem behaviors are not reinforced, if nothing else. So that they're not reinforced, so that they can be properly dealt with. The other difficulty, just to add to what you're saying, is that sometimes parents come and say that we bring the child to the child center for therapy. Now the child has started to behave like a absolutely perfect child, but that behavior of a perfect child is only centered to the child therapy center itself, right? So the problem's solution is that as soon as the child goes out of the center itself, either the parents are unknowingly motivating the wrong behavior, or that they're too tired from work and they sort of give in to the wrong behaviors that the child is showing. So eventually they are given some home plans, or they are guided as to whatever little time that you're spending, this is how you are supposed to be helping your child. This is how you're supposed to be dealing with the problem behavior of your child. The more you unknowingly start to reinforce, the more the problem will increase. It will not go down. So essentially, like I said earlier also, that every behavior is either fulfilling some need or a function, or it is acting as a way of communication for the child. So of course, all of that needs to be understood before we either increase a certain behavior or stop a certain behavior. So once that's done, of course, the children settle down, and of course, they sort of come back to acceptable behavior. I'll put it that way, acceptable behavior.
I was sitting in the clinic the other day, and this child was actually getting into a violent behavior. The first thing the parent did was to give the mobile, and hoping that it will appease the mood, because she herself was getting restless and not able to. Because I think for all of us, the show of a perfectly well behaved child is more important than the training the brain. So, I keep telling them that when we travel, we see children all over the world. They behave atrociously, and the parent just ignores. I have seen it all over the world where they are dropping things in the supermarket, they're shrieking, yelling, falling on the ground, rolling. But I don't know which one is the right thing, because sometimes when we tell them that don't give the phone on demand, there should be a time bar on all these things. It doesn't work, Medhavi. It doesn't work because the parent is going through such stress and there's so much frustration. I think, we need to do a lot of counseling for the parents where they will be able to relax, because the child is a child. So he is not doing anything that he doesn't know the right things, but the parent themselves are creating so much confusion in the brain by shouting. And I don't know whether the shouting is the answer to the entire issue, but I think there's so much frustration within our parents, so much frustration. And I feel that I want to go into every house and sit with them and hold their hands and say, be calm, because your calmness will get to the child one day. But it's not easy, because when you relate with them, they'll be shouting, Rekama, it's not possible. Today the workload was too high, it's hot, there are too many things for me to do. And on top of that, the child is behaving, and everybody is saying you have a badly behaved child. So you're listening to so many outside, forces that work on your brain. So, Medhavi, I think you need to open up your entire practice to helping the parents more than the child. Because once the parent changes their attitude and the way they are viewing it, which is, my child has Down syndrome, he is badly behaved, is not true. Is not true. Because every child will have sometimes when they will have good behavior, bad behavior. And we encourage one of them and discourage the other. But really, I mean, I'm getting more and more into this, because every day now that you're answering it, the way people ring me up and say, the child is throwing things out of the balcony and everybody is shouting at me because they're throwing things out of the balcony. So, how do you help a parent? I think you'll have to ask somebody to mute. Yeah, Medhavi. So, do we allow the parents to come to you for counseling? And so that, or do we have to necessarily see the child at his worst?
Absolutely not, ma'am. So essentially, whenever there is some form of problem behavior, there is no harm in seeking help at all, right? Like you mentioned earlier, brain is like any other body part. Mind is like any other body part, right? So essentially, every parent needs to understand that seeking help is not bad. Seeking help rather has become more essential than anything else in today's day and time, right? So we need to sort of understand as much as possible that one, seeking help is not bad, and two, of course, that seeking help for even the smallest problem behavior is what can help your child, not just that, but even stop the problem behavior in the very nascent stages itself. So understand that that is something that is very, very much required, and there is no fault in doing that. And no, we don't need to take our child to the extreme worst before we start to seek any form of help itself at any given point of time, right? So just to take things a little further from what you're saying, ma'am, you're correct in saying that there are too many extraneous variables, so to speak, that we call now the heat, the excessive pressure on the parents to perform at work, to perform at home, with the household chores and everything. So, of course, that's going to create nothing but frustration. But also at the same time, something that I keep telling every mother that I see day in, day out, 24/7, that until and unless you don't help yourself, your frustrations are going to get to your child. That's a sure, short, guaranteed way of irritating your child further. and also it's not going to help your child in any way. So help yourself first, reduce your frustrations first, then start to deal with your child essentially. And no, you don't need to take your child's behavior to the extreme worst before you start. Helping in the nascent stages will not just cure the problem behavior itself. I'm calling curing the problem behavior, not the child in general, not bringing the child back to normal, but at least making sure that that particular problem behavior sort of goes away completely, doesn't come back. That's the easier thing to do. Also, I usually tell all the mothers or the parents or the caregivers that I usually meet, younger the child, easier to deal with their problem behavior, easier to change the problem behavior. The child gets much more difficult before, difficult to treat, difficult to solve the problem, difficult to even reduce the problem behavior. Right? The more it continues, it's going to become a habit or an alternate to get what they want. Right? So seek help when you're not able to handle it. Seek help even if it is the most stupidest thing you think. But trust me when I say this, that the smallest of the problem behaviors can lead to much, much bigger problems. So seek help when it starts. Seek help.
Yeah, I'm surprised, Sammy and Parul. Nobody's asking questions. So they look like they've reached. If they ring me up tomorrow and ask me a solution, I'm going to tell them you should have heard this entire today's conversation. I'm not going to answer their questions. Otherwise, soon after this, there is one hand up, Dr. Medhavi. You're now getting questions.
Yes, ma'am.
Ma'am,
Yeah. So
நான் தமிழ்ல பேசட்டுமா
the doctor
ma'am?
is ready to answer certain questions. Dr.
Yes,
Selvi?
Dr. Selvi, Tamil
You can
பேசலாம்
answer.
நீங்க.
Ma'am,
I
நான்
will
கவிதா ma'am.
translate it. Yeah,
ma'am,
go
கவிதா.
ahead, go ahead.
Ma'am, என்னோட son வந்து 4.5 years ma'am. அவன் வாய் மென்னுட்டே இருக்கான் மேம். சம்டைம்ஸ் வந்து நம்ம யாருமே அவனை பார்க்காம இருக்கோம்னா வாய் மென்னுட்டே இருக்கான். டங்க்கு வளைச்சு வச்சு மெல்ற மாதிரி மெல்றான். அதே யாரு கண்ட்ரோல் பண்ணாலும் அவன் கண்ட்ரோல் ஆக மாட்டான். நான் பார்த்தா மட்டும் அதை அப்படியே கண்ட்ரோல் ஆக்கிக்கிறான். நான் செய்யக்கூடாதுன்னு அவனை பார்க்கும்போதெல்லாம் சொல்றதுனால அவன் என்னை பார்த்தா அதை கண்ட்ரோல் பண்ணிக்கிறான். அதே வந்து எங்க அப்பாவோ அம்மாவோ சொல்லும்போது அதை அவன் கண்ட்ரோல் பண்ண மாட்டேங்கிறான். அவனோட ஏஜ் குரூப்ஸ் பசங்க கூட கொஞ்சம் பசங்க கூட அவன் விளையாட ஆசைப்படுறான். ஆனா மத்த பசங்க எல்லாம் பார்த்தான்னா அவன்
So she's talking about not being able to get on with other children and a withdrawal, what we would call withdrawal. So என்ன சொன்னீங்க, எல்லா குழந்தைகளோட விளையாட மாட்டாளா? Hello? I think we lost them completely.
Hello.
Yeah. Chalo.
Could you get who was asking the question? I couldn't get who was asking. I thought Dr. Selvi is trying to speak, but she could not speak.
No,
Somebody
it
else
doesn't
was
look like
asking
it
this.
doesn't look like Dr. Selvi, so I'm wondering who it is.
Ma'am, can we request Dr.
Yeah. It wasn't
Medhavi
Dr.
to close the screen so that, ma'am, everybody can be visible?
Yeah.
Absolutely.
Dr. Medhavi, we can close the presentation as for now. So that
Thank you, ma'am. Thank you so much.
Questions we can address. Yeah. We don't know who was asking that. Dr. Medhavi, whatever is asked, you can give.
Okay, move on to the next one, Sammy, because
Yeah, Dr. Selvi, I think you can ask.
There is a question in the chat, ma'am. Can I go ahead and answer that?
Yeah, please.
Yes,
please.
Somebody in the chat has asked, can the behavioral issue be a result of some psychiatric issue requiring medical intervention? Absolutely. So like I said, that there are a lot of comorbidities for children with Down syndrome. that might require psychiatric intervention or medical intervention. There can, of course, be other medical related difficulties that can lead to some or the other problem behavior. We all know that children with Down syndrome have a lot of cardiac related difficulties, which can, of course, lead to other problems also, behavioral difficulties also. So, yes, there can be some. And psychiatric medication can be given at any age, depending on one, the age, two, the weight of the child, three, the height of the child, and four, severity of the child. Do all children with problem behavior require medicines? Absolutely not. Please understand, only the extremely severe cases which are not responding to any kind of therapy require psychiatric medication. One, and second, those medicines are extremely mild. They are not addictive at all. So please don't hesitate from taking your child to a psychiatrist if it is required.
No, Medhavi, I have a question for you. I'm going to call you Medhavi. One important thing is, is it important to go? See, there are many different opinions. Go to the neurologist, go to an ABA therapist, go to a child psychologist, go to a behavioral therapist. So the parents are not able to understand, is this a neurological issue? Is this a behavioral issue? Is this something that I need to do adaptive behavior or therapeutic behavior? So what would you guide us to do within that particular age? Because see, like you said, chronological and the other behaviors are based on age. So how do I realize where I should go first? Because I am very confused when the parents, they ring up and say, oh, I went to an ABA therapist and I'm doing behavioral adaptations and this, that, and all. So what would you suggest? Because our neurologists are drugging them. I'm telling you today. Okay, so here is where I need your expert opinion on charting this out and saying, for this particular behavior, if you see this at a certain age, who do you contact?
All right, ma'am. So essentially, just to give you a brief, every doctor other than a pediatrician, a clinical psychologist, and a psychiatrist, every other doctor, one will always drug the child. So child, by the time they reach us or the pediatrician or the psychiatrist, they've already taken so many medicines that their body is full of hormones that were given from outside, right? That's the primary thing. Secondly, when there is any behavior for a particular age which is not acceptable to you as a parent or a caregiver, two, which is harming either the child themselves or somebody else that they're living with, that requires help. Who can you go to? Your primary two people, three people rather, should be either a pediatrician or a clinical psychologist or a psychiatrist. Plain simple. In India, there is no degree that certifies somebody, legally speaking, as a ABA therapist or as a behavioral therapist. No, there isn't any. Legally speaking, on papers, by law, there exists no degree that deals with these 3-4 names that you just took. Ideally speaking, a child psychologist, an RCI licensed clinical psychologist, like you have MCI, clinical psychology has RCI, which is the Rehabilitation Council of India. They are all very qualified to look at any child with any difficulty. Ideally, the pediatrician or a child psychologist with an RCI license should be your only points of contact. Let's say, for example, that I am seeing, say, just in summer vacations, school summer vacations, essentially, I'm seeing anywhere between 300 to 700 kids just in summer vacations itself. How many of them actually require a psychiatrist? Probably just 5 out of 700. probably just 4 or 5, nothing more than that. How many of them actually come after doing all kinds of doctor shopping and having all kinds of drugs? At least 5% of them. At least 5% of them. So all of that goes to waste. That doesn't solve any problem. That just goes about increasing difficulties. It will not solve. Your only 2 points of contact should be a clinical psychologist or a pediatrician. That is it. Nothing else.
Ma'am, I have a follow-on question to this question that I sent just now. May I ask?
Absolutely, sir. Please go ahead.
Yeah, I'm Rajesh Matreja on Sanika Matreja's ID. See, the issue is as Ma very rightly articulated. While you mentioned this, that a pediatrician should be the first point of contact. Once a child grows beyond 18 and becomes an adult, the pediatrician is no longer available. And what we have experienced is that the doctors in general are kind of not aware or are hands-off approach about the psychological or psychiatrist problems, if I may, about it. So they'll say you go to a psychiatrist or whatever comes to their mind. And that's where the whole problem begins. Now, my son, being, for instance, being an adult with Down syndrome, has suddenly developed a repetitive behavior, far too repetitive, suddenly getting angry and all that stuff. So finally, we have ended up going to a psychiatrist. Now, the psychiatrist has written some medicines, drugs, as Ma said. Now we are really confused. I mean, because we don't want to drug him to the extent possible, precisely for the reason that you mentioned. Is it a psychiatric problem, a genuine problem related with the hormones in the brain, or is it something else? How do we determine? I mean, we are just confused. And I just Googled on the medicines only for my knowledge, and they seem to be for OCD. Now, I mean, there are more questions than what were answered. So, how do parents really determine what should be the next step? Where do we go?
Just to answer your question, sir, one, how do you determine? It's extremely difficult to determine for or me to be able to tell you what to determine out of a behavior. That's the very first thing. Secondly, is only psychiatry or medication the final answer? No, not necessarily. Two, does repetitive behavior occur only in OCD? No, not necessarily. It can occur in 100 different kinds of problems. What your child is doing, I don't know, so I cannot comment. But ideally, if psychiatry does not help you out or solve your problem, your next point of contact should be a psychologist. That's all I can say for right now. But repetitive behavior, so to speak, one, is common in children with Down syndrome. Two, having a comorbidity of OCD is also about 3 to 4% of children with Down syndrome might end up developing OCD also. So it can be that, but without seeing the child, without knowing the complete history, I will not be able to comment. But if you feel lost after visiting a psychiatrist, please speak to a clinical psychologist.
Okay.
Hello? Hello, ma'am?
Yeah. I'm there. I heard.
Hello, ma'am. I am
Ma'am,
Dr.
please unmute yourself. Rekha ma'am.
Hello?
Yeah.
Yeah.
I
Yeah.
hope, Mr. Matreja, you've got your answer.
Medhavi,
Well, not
normally,
So
really,
we
Hello?
would request parents to please come on.
because
yeah.
like I mean, while we went to the psychiatrist, all I got is that I'll have to go to a psychologist. But for all one knows, maybe the psychiatrist is right, maybe he's not. That's where the whole confusion is.
True, but then to analyze whether my child is on track with a particular medicine, you have to give at least 6 months. See, what is happening is parents, once they start with the medication, they give it up to 6 months and retract. They stop the medicines. And this is where we are having a double dose. It'll come back in a double whammy because I know it happened to Bubbly. for 2 years, she was on psychiatric medicine between the ages of 19 and 21. And I thought she had been cured. Now, one thing you don't do, it's like diabetes where you can't suddenly retract a medicine. And the minute we stopped it, her brain levels again went, haywire. She went into a completely no zone. And yes, like you said, the behavioral issues will be no talking, no social contact, etc., etc. I am saying medicines cannot be stopped. So for every behavior, like I'm talking about adults, I'm not talking about child, I'm talking about the adults. You look at hallucinations, you look at depression, you look at schizophrenia, you look at multiple mood disorders, mood swings. So the tablets we are giving have to continue for.
Ma, you got muted. Rekha, Ma, you got muted.
Hello.
Rekha, Ma, you got muted.
Yeah, ma'am, I got it. I'll consult you separately. Thanks a lot.
Madam,
Hello,
good
ma'am. Good
Hello.
evening.
Dr.
Hello.
Sylvia,
Yeah, ma'am. Good
to you
evening.
finally. Please
First of
ask
all,
questions.
I'm thankful to you for the wonderful presentations, and this is the subject is I am eagerly waiting to know more about it. Now, my question is,
Ma'am, please go ahead.
Dr. Sylvia, we could
Oh,
hear you. The question is.
pardon?
After that, we lost your voice.
Hello.
Yes, ma'am.
Yeah, the
Yes,
child
ma'am.
is
Ask your question.
attachment with the objects like a toy or a.
So we are losing your voice, Dr.
So
Sylvia.
how?
सिल्वी, आपकी आवाज बार बार जा रही है. आप अपना जो मैसेज है वो टाइप कर एंड चैट बॉक्स में से कुछ सवाल लेने हैं समीक्षा.
Hello.
Aditi?
Hello, ma'am. Please. Hello.
Who's this? Please raise your hand. We will ask the question. Request the question. The people who have raised hand to ask first, and then we'll come back to you. Please raise your hand.
Raise hand.
Aditi, can you unmute and ask?
మీటింగ్ రావట్లా.
Mohit, Kavita, if you can unmute and ask.
Okay, ma'am. Ma'am, my son 4.5 years, ma'am. அவ வந்து வாயில டங்க் வந்து ரொட்டேட் பண்ணி பைட் பண்ணிட்டே இருக்கான் மேம். அவன் சம்டைம்ஸ் அவனை தனியா நம்ம விட்டோம் அப்படின்னா அவன் ஒரு இடத்துல போய் உட்காந்துட்டு அந்த டங்க் ரொட்டேட் பண்ணி மென்னுக்கிட்டே இருக்க மாதிரி இருக்கான். அது என்ன செய்யுது? நான் என்ன பார்த்தேன்னா செய்யக்கூடாதுன்னு சொல்லும் போது அவன் அதை செய்யாம இருக்கான். அது சேஞ்ச் பண்ண முடியுமா மேம்? அது
Medhavi, this is a physical thing. The tongue, he is not able to keep it within his mouth as most children with Down syndrome, and he keeps rotating it, and he holds it with his hand, and when she says to stop, maybe he will, but we don't know whether her saying it is creating more confusion, and he might, I don't know whether there's a psychological issue behind this.
Right, ma'am. So, like I mentioned in my presentation as well, one, we need to understand if that is a sensory issue. Secondly, of course, we also need to look at when it is happening, how it is happening, how frequently it is happening. What it is leading to is what needs to be
அவன்
figured out.
ஆல் டைம் அதை அவன் செய்ய மாட்டேங்கிறான் மேம். எப்பயாச்சும் தான்
சரி, நீ அப்புறமா
தனியா
எனக்கு
இருக்கான் அப்படின்னா மட்டும்தான் செய்யறான்.
சரி
Okay, ma'am.
எனக்கு ஃபோன் பண்ணு, நாங்க பேசலாம் அத பத்தி. ஓகே, நான் பேசுறேன் உன்னோட.
Okay, ma'am. Okay, ma'am. Thank you.
Yeah.
Hello, ma'am.
So I think Dr. Medhavi, question?
Hello. Can I ask question, ma'am?
Please go ahead.
Just a second. Dr. Sylvia stated the question. Let us ask that. She's asking that how to wean off the self-advocate from the attachment to the box or a toy or a bag. So what will be the
How do
procedure? Then
we
Gayatri, we are
know?
taking your question. Yeah. Yeah.
How
If
do
the
we know
if the
the
self-advocate or
attachment?
person is attached, yeah,
Yeah.
to an object, a toy, a bag.
Right. Okay. So one, you need to figure out what the attachment is with. Two, what if the attachment is leading to something that is non acceptable or inacceptable. If the child is taking that attachment toy bag or something to every situation or every place they are going to, then it is a problem. That's the first thing. If it is causing trouble to other people, then it becomes a problem. You do not remove the attachment if it is not creating any trouble. Next, depending on what the child is attached to, there are various techniques that can be used to remove the attachment. Which technique to use will depend from one case to another. So I will not be able to comment on how and why you should be able to remove the attachment, because not every technique might be useful for every child. So I will want to know a lot more than attachment to a box or a bag before I comment on how to remove it.
I agree with you totally, Medhavi. I think we need to know the purpose of what they are attached to. The purpose is what we look at rather than looking at what they are carrying. Because if their parent is objecting to it, it is a parental issue, not a child issue. So we normally try to find out, because my daughter till now will carry something in her hand because she has to be shaking it for the purpose that I think it gives stability to the body. So it is each one's right to do what they want to and stop discontinuing most issues. These are not relevant issues at all. But I need to talk to parents and explain in first, like everything goes back to my daughter. Otherwise, they don't understand. It is when a parent has been through it that you can explain that it's perfectly okay if he's carrying a box and walking around on the streets. It depends on what it is. And if it is not endangering anybody else's life, I think it's perfectly okay.
Totally agreed, ma'am. Absolutely agreed. And if it's not harming the child, not harming anybody else, it does not need to be removed at all.
And the parent should stop, taking away things from the child because they don't like it. So this is what is very upsetting, because it is about me, not the child. So first talk to the child, explain to the child. There's this constant, talking between parent and child never happens. It's like the right of the king. And when I say it has to happen, it doesn't happen that way. So relationships very important, that you give the child importance in any conversation.
शुक्रिया डॉक्टर रेखा
Absolutely.
एंड डॉक्टर मेधावी। समीक्षा, अभी और सवाल भी हमारे
Yeah,
पास
we
है,
have a
हमारा
question.
प्रेजेंटेशन भी डॉक्टर का
Yes,
बाकी है और
time is
हमारा
also
समय भी
done.
समाप्त हो गया है। क्या किया जाए?
No,
Yeah.
I think we take this one question of Gayatri. I don't know what she has.
Yes.
Hello, I am
Yes,
Gayatri
Ma,
here.
she is typed. I'll read, then Gayatri can add on. Gayatri writes that my 15-year-old daughter with Down syndrome suddenly attacked with seizures during sleep. She didn't have any other clinical issue before. Is this happening due to her adolescent age, her hormonal bloom, or excitement? Please, your guidance.
Right, ma'am. So one, why seizures happen can have very many causes. That's the first thing. Does every cause lead to a seizure? Not necessarily. Sometimes causes for seizures are also unknown. Seizures cannot be caused because of adolescence. No, absolutely not. Seizures can be caused of multiple known issues. They can be caused because of unknown issues also. As far as seizures are concerned, there are set medical protocols for seizures. They range from anywhere between 3, 5, 7, or 9 years of medicine. And if the child responds to the medicine, the seizure will stop. but there are certain types of seizures which are also medicine resistant. So the medicine, a mild dose might be required for a lifetime. The child has to, I'm repeating, has to be taken to a neurologist after a seizure. So please take care of it. Seizure medicines they simply cannot stop randomly because the parent does not like it. Seizure is a medical issue. It requires serious attention and it can lead to serious other medical issues if it is not treated properly. So please listen to your neurologist if your child has seizures. No other specialty can help you in seizures. Please remember that.
Gayatri,
She's
you have
already
any
taking
additional?
seizures medicine. Yes, she's already taking medicine. She's under neurologist supervision only. But my concern is without any issue, she suddenly got seizures during sleep only. That is what I want to know. Any issues regarding this hormonal blooms? And nowadays she is so much excited with the school and friends.
Gayatri ma'am, this is hard. This is hard to ask and hard to answer for a doctor also, that why this is happening now.
No, so I'll just still go ahead and try and answer Ms. Gayatri's difficulty. One, what sort of problems seizures can cause, we still don't know. So what part of the brain the seizure affects will lead to some or the other behavioral difficulty. So one, the excitement itself can be blamed on the seizure itself. It can be blamed on adolescent itself. But can we say for sure that adolescence or seizure is what is causing the excitement? No, we can't. We can definitely treat it symptomatically by some behavioral therapy techniques. But for that, I will have to know a lot more detail than just a description of excitement itself.
Okay, Gayatri, you are muted. Gayatri, you have to unmute.
Only when she's awake, she's fine. She never got any issues. Only during sleep, suddenly it lasts within 1 minute only. Again, after 15-20 minutes, she's become normal. She underwent brain this MRI. Everything was normal. Sleep easy was normal.
I understand that, ma'am. So like I said, it can be a seizure related thing. So one, you need to be able to speak to a neurologist for this. And if the neurologist does not sort of solve your problem, maybe consult a clinical psychologist or a psychiatrist for that, and they'll be able to help you better.
Okay. So neurologist also telling we cannot say with what age it may come any age, any cause will be there. Unknown cause also will be there. That is what they are telling. But she is under medication since 8 months. But with medication never repeated, she is taking daily dose.
Right, ma'am. I can totally understand. So like I said, that it can also be an unknown cause. So we need to further evaluate how, when, what are the consequences of the difficulties that you're seeing before we go ahead and give you a full force solution to solve your difficulty.
Okay. Okay, thank you, ma'am.
So, yeah, I know, Dr. Medhavi, we have overshot time, but I think there are one or two more queries you would like to answer, because a worried mother can only get a satisfaction only when an expert answers. This is about a parent is asking about the 17-year-old son who gets nightmares and screams in the night very often. He's also scared of dark, though we keep a night lamp on, and stays awake till 1 a.m., getting up late in the morning. If you can just help this parent, right? sharing your
Right. So
experience and
one,
advice.
nightmares and night screams are one issue that needs to be dealt by a professional. That's one thing. Secondly, whatever is happening after that, staying up till 1 a.m. And getting up late in the morning. If the child is, of course, staying up quite late in the night, all of that will lead to him or her lead to waking up late in the morning and all of those difficulties. Nightmares and night screams can be quite terrifying for a child itself. Night lamp might not solve your problem with just that. So one, we need to figure out what the content of the nightmares and night screams are. And maybe from there on, it'll be easier to help your child out. Night lamp might be difficult. So one solution that I usually give to parents is that you can spend some happy time with the child, or you can do some fun activity or remind the child of something fun, or tell a long fun related story right before bedtime. So that should one, at least delay the nightmare, if not stop it, but it should also help you bond with the child. Other than that, children with Down syndrome in general are fearful of a lot of things. So maybe some other professional help is what is needed, and the nightmares can just be a side effect of random fears that he or she has. So a lot more detail again is required for that. And nightmares, of course, can be debilitating for a normal child, let alone a child with special needs. So more needs to be looked into it.
I'd like to add that they must check on what is being seen before sleeping.
Absolutely, absolutely.
Yeah, because many of these people are they watch these movies. Any movie today will have some violence, and I find that as a huge impact on the brain of our children. And it's not because they are Down syndrome with any child today. And if they are scared of the dark, leave on the light. These night lamps don't help. So leave on the light in the room. It's going to help the child. And please, please, like you say, happy moments in the night. Talk rather than see a movie.
Absolutely, that's exactly why I said, ma'am, revising on happy moments, seeing something happy, seeing some jokes, seeing some cartoons which make them laugh, or doing something fun that they find is what is required right before bedtime, rather than watching nowadays shows which will always contain something or the other, which is, if not negative, then at least neutral. So it's not bringing in any positivity. So one, that is something that needs to be changed right away.
Here you have to change the parent, Medhavi. They have to be happy people first.
Absolutely, absolutely, absolutely.
Laugh with the child. The parent himself has to be a happy person. It's not always the mother. I find the father is also becoming very grumpy by the end of the day. So we need a mindset, mind change, and a lot of talking to people. God, Medhavi, the amount of work you guys have. You got to look at every angle of everything of a parent, of a child, a grandparent. So your work is never going to stop, okay? So you've got a long journey to go ahead. And thank you so much. Are we waiting for Dr. Smita to come in and join us? Yeah, but Medhavi.
Yeah, Dr. Smita is there. We are very happy to have her.
Yes,
I'm
but
sorry
Medhavi,
for being late. My dog got a really tough thing and now going for a IV drip. So,
yes, we know, Dr. Smita, you are too busy, but we are so happy to have you for some time also.
Only thing I really wanted to know, okay, what about pets' relationship with babies with Down syndrome, trisomy 21? Is there any help?
Excellent. I cannot tell you, my daughter grew up with a Doberman.
Yeah.
And you know, they are so close to animals that it is like the closest thing to their heart, because I think their heartbeats match. the purity of the two souls is so beautiful. I mean, everyone who has an animal at home will understand what I'm trying to tell them, because it is they talk to them. When you say speech therapist, I think there's no better speech therapist than an animal, because they're cuddling it and they're able to show their warmth, and people with Down syndrome are the warmest people. So it is like a mind changer for them, where they have an animal next to them, and if the animal is injured or unwell, they will be the first people to know about it. So thank you for that question. It really, really brings back a lot of things that had happened in our lives.
So I think, Ma, Ma, it's so nice to hear you. I think I'm right. Rekha Ma is there.
Yes.
I can recognize the energy in your voice. I cannot see your face, but it's a good fortune to hear you. And also, I really wanted to know that I know that in Down syndrome, you go for a photo picture, like whenever you're trying to make a baby learn something, they are more receptive towards the photographs and all. So I think they should be really regularly going to the museums or zoo, and although Chidyaghar mein na, like you see the animals, you see the things, then they probably will understand in better way. Is it so?
Absolutely. You won't believe it. Let me give you one example. I'm always going back to Bubbly. When we never had color picture in those days, we had only black and whites. So 40 years ago, whenever we showed her the photograph of a horse, a dog, a goat, or a sheep, she would say it all looked the same. It's all four legs and a tail. So we had to start taking her to the zoo, to the farms, to relate with animals. I cannot tell you how beautiful those pictures came out, because she was touching the animals. In fact, we did one thing. We even brought an elephant home, because those days the elephants used to walk our streets. Now, of course, I don't even know whether people allow elephants on the streets. But for us, the elephant puja was so important. We brought the elephant home and she gave it a bath. So she touching it, feeling it is, I cannot tell you, those pictures are so vibrant in her mind that you have to realize that a child remembers being with animals or being with people. Yes, photographs, like you said, visual images are the strongest in their mind.
Yeah. So that's a nice idea. I just came up with this idea just now, and I will definitely advise my children, my patients, that they should definitely visit more of museum, but rather zoo, because animals are so lively and have their own energy. So probably that will be a really nice thing. So you are absolutely right that the parents should be very happy, and they should be like more giving and have gratitude. So then only children actually imbibe those qualities. So that's great about you, Ma.
No, actually, it's lovely to see you, because it's like, distances don't matter these days. We are always able to see each other. And this Saturday evening is always amazing. And Dr. Medhavi has opened up a huge Pandora's box where brains are going to start working, where we are thinking of how do we do this? And we're going to get back to you, Medhavi. I think all the parents are going to jump on you, because we have very few. Like Hema has put up a thing which says, do we really have what is called a behavioral therapist?
Exactly. Yeah.
That's very frightening, Medhavi. We can count them on our fingertips. So behavior is such a big concern for parents, because everything they put it back to good behavior or bad behavior. And I think sometimes you have to let things go, because children settle down in their own time, And today the word hormonal changes has become so huge. So I think we need you more often, and at least we need you at least once a month, because the subject that you have touched on is very close to a parent's heart, and they're able to open up, because more than medical, these are issues that we're not able to find the right people. Am I right, Sammy and Parul? Can you say thumbs up?
Absolutely. Absolutely.
So I think we cut through Medhavi's entire presentation.
हम
We didn't-
लेकिन उसके लिए उन्हें
Exactly.
दोबारा से फिर इनवाइट करेंगे और जहां उन्होंने सवाल पूछा है उसी सवाल से
Yes.
ख्याल से
Yes,
समीक्षा
you
में
definitely.
शुरू करना ही पड़ेगा।
Okay.
तो
Absolutely.
आज का लेकिन इतना जानकारी भरा सेशन रहा है, मुझे लगता है कि और बिल्कुल नॉन स्टॉप जो चला है ना, किसी को बीच में बोलने और आने की जरूरत ही नहीं पड़ी, सीधे सवाल सीधे जवाब। तो बहुत अच्छा सेशन रहा, मुझे लगता है आप लोगों को बहुत कुछ जानने को मिला होगा। और समीक्षा, क्योंकि बहुत टाइम आगे हम पहुंच गए हैं अपने उससे, लेकिन सबसे अच्छी बात ये रही कि जाते जाते डॉक्टर स्मिता मिश्रा जी हमारे साथ आ गई हैं, हमसे जुड़ गई हैं, ये बहुत अच्छी बात रही। और बहुत ही अच्छा इशू उन्होंने उठाया कि बच्चे पैड्स के साथ कितना करते हैं, कितना अच्छे से करते हैं। बहुत बड़ी एक थेरेपी, एक ये पूरा टॉपिक हो सकता है कि कितनी बड़ी थेरेपी पैड्स हमारे बच्चों के लिए हो सकते हैं। तो आज का सेशन हम यहीं समाप्त करते हैं। समीक्षा, आप सबका बहुत बहुत धन्यवाद। लेकिन जाते जाते एक खुशी है जो आप सबके साथ हम शेयर करेंगे। आज हमारे साथ हमारी जो दोस्त हैं रश्मि जोशी जी, उनका जन्मदिन है और जाते जाते हम उन्हें
Yes.
जन्मदिन की बधाइयां देंगे।
Happy birthday, Rashmi. You're looking gorgeous.
Happy birthday, Rashmi ma'am.
Happy birthday to you. Happy birthday to
birthday
you.
to
Happy
you.
birthday,
Thank you.
Happy birthday to
Love.
you.
For enriching us, and we will
you.
definitely trouble you once again.
Yeah. Thank you so much. Ma'am, just one question for you, Medhavi ma'am. Is it okay if you share your mail ID with us, and if
Yes.
people want to connect?
If the parents want to connect to you
Okay, I'm
because
just
they are
typing
connected.
that in the chat itself.
Right, please, ma'am.
Yes. Yes.
Thank you.
And
I hope I
later, Brinda, we will request that you can also share in announcement group her connect.
I
Whatever
will
connect.
be doing that. That's why I asked her for it. Thank you.
So she.
So, Dr. Madhvi, thank you so much
Yeah,
on the
yeah,
behalf
yeah.
of best also. Yeah.
Thank you so much, ma'am. Thank you so much for this opportunity. I'll be more than happy to be associated with Down Syndrome Federation of India, and I'll be more than happy to be coming back to these Saturday topics.
you don't have an option now.
I know. I know.
जो
Thank you
हमारे
so much.
पास आ गया।
God bless
Yeah.
you.
Yeah. Thank you.
वृंदा जी,
Thank you, everyone.
much,
I'm ending
Smita
the
ma'am.
session now.
Thank
Thank you,
you
Medhavi
for
ma'am.
being
Thank
there.
you, Smita ma'am.
Thank you,
Thank you,
Brinda.
Paul and Stanley. And
It's a
thank you,
big
Rekha
blessing.
ma'am. Bye,
Thank you,
everyone.
everyone. Thank you, Dr. Medhavi.